we're going to discuss early non-small cell lung cancer and medical management. So greetings to you from my city, Bangalore, and my country, India. So let's first define what early non-small cell lung cancer is. It's essentially stage 1 to 3A, where we look at these stages with surgery being the curative intent. Now, for this curative intent, these are the various types of surgeries that are done. I've just put a pictorial graph here. And in spite of this, they do come back with locoregional and distant metastasis. And this is a slide to show you where all they can recur in the region. Now, if you look at stage 1 to 3A, almost 25 to 30% of these patients undergo surgery with the curative intent that I mentioned. But you must remember that almost 70% of these patients come back with systemic relapse. And this actually signifies the importance of looking at some sort of medical management for these people in terms of adjuvant therapy to decrease the systemic relapse. So this is looking at the survival in non-small cell lung cancer, looking at stage 1, 2, and 3A, essentially the early non-small cell lung cancer. And this is showing you 1 year, 3 year, and 5 year survival. And if you look at the last line for 3A, the 5-year survival is a dismal 26%. So as the stage increases, the survival also falls. Then this is looking at local recurrence versus distant relapse. And again, the distant relapse for stage 3A is almost 60%. And even in stage 1A, there is a significant amount of distant and local relapse that occurs. And therefore, I will tell you why even stage 1A needs adjuvant therapy. So the question that all of you would be asking is, what is the survival benefit when you give adjuvant therapy with completely resected stage 1 to 3A non-small cell lung cancer? And I'll show you some evidence as to why this is important and what the benefit is. So in the 70s and early 80s, they looked at adjuvant chemotherapy to improve survival, but they found that the evidence was not consistent in terms of benefit, and adjuvant chemotherapy was not widely used. And this was because the chemotherapy at that time was poorly tolerated, especially because the access and the availability of supportive care was very, very limited, including antiemetics. So that was the sad part at that time, that chemotherapy fell into disrepute. In 1995, there was a meta-analysis that included over 4,000 patients from randomized trials, and this actually failed to demonstrate a survival advantage. But then they looked at a subset of these trials which used cisplatin-based chemotherapy, which did suggest that there was a survival benefit. Therefore, this evidence pursued people to follow giving this adjuvant chemotherapy for completely resected non-small cell lung cancer. So in the 5 trials that did not contain cisplatin, there was no survival advantage of giving chemotherapy for these patients. Whereas other 8 trials that had the use of cisplatin, they found that there was a definite decrease in the risk of death, which translated into 5% at follow-up of 5 years. So 5% at 5 years is a number you need to remember, and that is pretty significant. So again, showing you the same thing, that the hazard ratio from this meta-analysis was 0.87 with a p-value of 0.08 and a 5-year overall survival benefit of 5%. Now, just to mention some of the important chemotherapy adjuvant trials are listed here. The IALT trial, which had cisplatin-based chemotherapy versus observation. BR10 trial, which had cisplatin, vinorelbine versus observation. CALGB 9633, which looked at carboplatin, paclitaxel versus observation. And the ANITA trial, which looked at cisplatin, vinorelbine versus observation. So this is the IALT trial for you, which was published in NEJM way back in 2004. And this was the study design, almost 1,000 patients in each arm. And this did show that there was a survival advantage for the arm that got chemotherapy with a significant p-value of less than 0.03. And the absolute benefit at 5 years was 4.1. And in terms of absolute life saved, it was 7,000 per year. This is the next study, the JBR-10, which had almost 200 patients in each arm, randomized between vinorelbine, cisplatin, and observation. And again, this also showed that there was a definite advantage of giving this combination as adjuvant therapy with a hazard ratio of 0.06 and a p-value of 0.04. Now, as you can remember and see in your practice that a lot of our patients who come are elderly. So this study looked at this particular aspect, whether adjuvant chemotherapy was beneficial in the elderly. So of these 482 that were randomized, the elderly were 67 patients, and they followed up these patients with a similar chemotherapy, and they showed that even the elderly, there was an advantage in terms of overall survival and disease-specific survival, because most of the time we feel that the elderly will have toxicity of chemotherapy and will not benefit. But this study actually showed that it was definitely beneficial to give adjuvant chemotherapy even in the elderly. So this is showing you the overall survival in all patients. And this is in the elderly, like I mentioned. So I showed you just two examples of two studies, but what was the summary from all these randomized trials was that the IALT supported platinum-based chemotherapy, and the results were moderately significant. PR10, which I showed you, had a statistical advantage in prolonging overall survival. CLGB showed that the risk of death was significantly lower in the arm that got chemotherapy. And in the ANITA trial, the overall survival and the relapse rate significantly improved in those patients who got vinorelbine and cisplatin as the adjuvant chemotherapy. So, who are the patients who will be eligible for this post-op chemotherapy? The indications are those patients who have these PTM figures, PT2N0M0, PT1T2, N1M0, and PT3N0 to N1 and M0. And as of now, not extensively indicated in PT1N0M0. So this is a forest plot just to show you the advantage of adjuvant chemotherapy. If you see the upper part where the older regimes were used, you can see the pink diamond lies towards the side which did not get chemotherapy. In other words, chemotherapy was in fact harmful. Whereas if you come to the second one where you can see the orange diamond, it is towards chemotherapy, and lower down where the regimes included cisplatin, you can see the blue diamond definitely towards the arm that got chemotherapy. So it was not that the chemotherapy was not useful, but the toxicity was pretty high, the supportive care was not adequate enough for us to see the benefit. And use of cisplatin definitely has shown that it's an important drug for these patients when you give them adjuvant chemotherapy. This is the LACE meta-analysis, which is lung adjuvant cisplatin evaluation. Again, to show you that use of cisplatin is very, very important. And these are the 6 trials that are here, 5 trials and a total one here, showing you that for all these trials that did have chemotherapy with cisplatin as a backbone, there was an advantage of using chemotherapy. And you can see all the dots are to the left towards the chemotherapy arm, the chemotherapy effect having a p-value of 0.004. Now this is looking at the same meta-analysis stage-wise. And if you see here for stage 1A, there was not great benefit of this chemotherapy with a hazard ratio of 1.41. Whereas for all other stages, it was definitely an advantage to use chemotherapy. So this is the summary of this meta-analysis that demonstrated a significant, statistically significant benefit of 5.4%, being the absolute survival benefit, which is in favor of adjuvant-based cisplatin-based chemotherapy, with a median follow-up of these patients of over 4,500 of 5.2 years. Now, this is again just diagrammatically to show you that with the increasing stages, the advantage of chemotherapy increases. For the early stages, the blue part is the one that who benefited by receiving chemotherapy, you can see that with increasing stages, the blue part of these bars keep increasing. So this is a diagrammatic way of showing you the advantage of adjuvant chemotherapy with each stage. Now in 2007 ASCO, Dr. Stewart presented this particular meta-analysis which used individual patient data. People believe that using individual patient data for a meta-analysis has a larger strength to the outcome of these randomized clinical trials. And this meta-analysis confirmed that the adjuvant chemotherapy in resected non-small cell lung cancer produces overall survival benefit, recurrence-free survival, local recurrence-free survival, and distant recurrence-free survival. And you can see all the p-values for these 4 points being so significant. Now, the other question that came in at this point of time was whether you could replace carboplatin to cisplatin. And this was a meta-analysis called CISCA meta-analysis, which actually compared all the randomized clinical trials which had cisplatin and carboplatin. And the primary endpoint was overall survival, and the secondary endpoint was response rate and toxicity. There were almost 3,000 patients in these two arms of carboplatin and cisplatinum, and the response rates for cisplatinum was 30%, and for carboplatin it was 24%. Carboplatin was associated with a relative risk of death which was 7% higher as compared with cisplatinum, and therefore the compelling evidence that in an adjuvant setting in non-small cell lung cancer, you always need to use cisplatin and you cannot replace it with carboplatin. So this is an important thing for all of us who need to remember who treat non-small cell lung cancer. Now the chemotherapy agents, cisplatinum-based chemotherapy agents are preferred. Initial advantage was seen with cisplatinum and vinorelbine. The other ones that have been tried are cisplatin with etoposide, gemcitabine, docetaxel, and carboplatin. And like I said, carboplatin is a thing that we need to avoid in an adjuvant setting. Now, some of the other novel adjuvant approaches that have been looked at is the use of pemetrexed, because it's a very safe drug. Targeted therapies, I will show you some evidence for that. Vaccine trials, genomic stratification, I'll show you some evidence for that as well. And immunotherapy has very rapidly come into the adjuvant setting. And other risk factors trying to look at vascular invasion and targeting the microenvironment. So this is data for the use of adjuvant pemetrexed in non-small cell lung cancer. And this was published in 2013. And you can see that combining cisplatinum with pemetrexed can be a good alternative to the older vinorelbine and cisplatinum arm, especially pemetrexed as compared to vinorelbine is a much safer drug as we have seen in its use over several years now. Now, as I showed you in stage 1B, 2 and 3A, adjuvant chemotherapy is beneficial. In 1A, there was doubt. But again, we see that in 1A, 25% of these patients have a recurrence. And therefore, we today believe that histology is not the optimal thing, and it will soon be replaced by a lot of molecular profiling, which Dr. Ullas showed you in terms of when you're treating advanced non-small cell lung cancer. So this was a paper which was published by Dr. Bhattacharjee in 2001, which is almost 19 years ago. And at that point of time, he made a bold statement that at best, histology is a crude molecular selection, and we definitely will have to look at molecular profiling. The same thing has been done in the stage 1A disease in two of these lung metagene model studies, which involved not too many patients. The first cohort was 25 and the second one was 84. And this lung metagene model, which was applied, had a predictive value of 72% in the first study and 79% in the second study. So in 1A, where we know that 25% would recur, it would be worthwhile looking at this particular metagene model and try and see who are the ones who would benefit most with chemotherapy here, because like I said, 25% recur and 75% will not. So if we give a blanket adjuvant chemotherapy for everybody, almost almost 75% of these patients would have toxicity. So till now, 1A was not under the ambit of adjuvant chemotherapy, but then 25% of these patients would not get the benefit. Therefore, this is a good way of looking at the gene profiling to try and pick those patients who would benefit with adjuvant chemotherapy. Now, what about targeted agents in adjuvant treatment? Ullas very nicely showed you about targeting EGFR and ALK. And this was one of the, initially a lot of people have used geftinib and erlotinib in the past for adjuvant therapy, but most of those studies did not show any benefit. This was one recently published study. This is looking at geftinib in Chinese patients who had complete resection but were EGFR mutated, and this was the study design. They were randomized between geftinib and vinorelbine and cisplatinum. And what came out of this study was that those patients who received geftinib, the disease-free survival was 30.8 versus 19.8 months for those who got chemotherapy. The median overall survival, 75.5 versus 62.8 months in favor of geftinib. And the prolonged overall survival was observed in those patients who got a geftinib for over 18 months. But if they got it for less than 18 months, this benefit of overall survival was not seen. So in case these patients get adjuvant geftinib, they need to continue it for at least 18 months. So this is an important thing that came out of this study, and I'm sure people will start using it more and more now. The other one which came out again was the use of osimertinib in this adjuvant setting. Again, to show you that this study did not have any stage 1A patients. They go from 1B to 3A, and this is the study design. Osimertinib at 80 milligrams per meter OD. And I think since you have the generics in your country, it'll be very nice for you to use it, or maybe even run a study and see whether you can duplicate this data that this study has shown. So this is to show you the DFS by stage. And as you can see, for 1B, it is not very significant. Of course, there's a difference. But for stage 2 and stage 3, even with your naked eye, you can see that these curves are separating very, very early, and they continue to separate even after 48 months of follow-up. So there is a distinct advantage of using this third generation EGFR TKI in these patients. Now, this is early overall survival data for you at a follow-up of 24 months. And in the arm that got osimertinib, it's 100%, whereas in the other arm, which got only placebo, it was 93%. So again, showing you that although it is too early, it seems that there could be a survival, overall survival advantage as well. So these are the limited data that we have today for use of targeted therapies in adjuvant setting. So the conclusion again was that there were no new safety signals with osimertinib. In fact, it's considered a drug that is even more safer than geftinib, and therefore a lot of people tend to use this in the first line metastatic non-small cell lung cancer. So today, the recommendation from these investigators, as most investigators would say, is that osimertinib should be incorporated into standard practice for treating these patients in the adjuvant setting following resection. Now, this is one study of immunotherapy. Like I said, immunotherapy from the metastatic setting has come in very rapidly into combination with chemotherapy, single agent, in the neoadjuvant setting, and now in the adjuvant setting as well. And this is the study designed for you. I'm sure we'll have data soon from this study. So to summarize, for adjuvant chemotherapy in the setting of completely resected non-small cell lung cancer was a subject of controversy for a long time. But as I've shown you, over time with better drugs, better understanding of the biology, and better supportive care, we've shown that adjuvant chemotherapy, especially with cisplatin backbone, is here to stay. There is statistically significant survival benefit with the newer chemotherapy drugs. Toxicities, which remained an issue, are well taken care of today. And targeted agents, as I showed you, are making progress, including immunotherapy that are coming. With that, I think I will stop, and thank you very much.